I appreciate everyone that's on here today. I'm going to get my chat. As she said, I'm going to try to watch the chat as the presentation goes along. So if you have questions, feel free to pop them in there. If I don't see them, they are going to interrupt me to make sure your questions get answered, because I hate waiting till the end because then we don't really know what the context was when the question was asked and stuff. So feel free to shoot questions, to interrupt, to do what we need to do to make sure that you all get from this what you want to. So the poll was not as telling as I had hoped, but that's good because it means we have people from a variety of disciplines or backgrounds, perhaps folks that are in administrative roles that don't work in direct service, maybe with the not applicables, or individuals of the public that are just interested in this topic, maybe regulators, state authorities and stuff. So that's great. It's always kind of a trick question when we ask if you provide MAT, because that can mean so many different things. Even though there's just 3 medications for opioid use disorder, we find that MAT means a variety of things. So what we're going to talk about today are all 3 of the medications. Let me get see if I can get my slides going here. Okay. All 3 of the medications for opioid use disorder. We're going to do some highlights on some of the basics. Even folks I've found in the field that are familiar with MAT or have worked in the modality for a long time often aren't exposed to some of the base science that it seems everyone should know. So we're going to hit some of that, but ultimately with a setup to residential programs. So your learning objectives today to be able to, we're going to hit real quick the current epidemic we're facing, to be able to describe all of the FDA-approved medications for opioid use disorder, the different modalities where we can use it. It's often thought of as an outpatient modality, but it doesn't have to be, and it shouldn't be only. The barriers for using medications in treatment historically and presently, and to describe at least one example of a traditional residential program implementing MAT. There's a couple of examples out there. I've done some TA for the ATTC in Alabama for a residential program to help them implement MAT into their continuum. And at least 3 ways we can use MAT in residential programs. Also the negative impacts of stigma, of course, and how that can impact individuals from finding recovery. So real quick, we're in this epidemic. Everyone sees it on the news. I think it's important, one, to point out that despite the rise in opioid overdose and opioid use disorder diagnoses, alcohol use disorder remains the #1 killer as far as SUDs are concerned, and in many areas of the country, certainly in the rural areas of my neck of the woods here in North Georgia, Eastern Tennessee, Western North Carolina, Southwestern Virginia, I'm kind of all over that whole little area. We're seeing a rise in stimulant use disorders with methamphetamine. But specifically to the opioid crisis that we're facing and a larger substance use crisis in the United States. How did we get here? We don't want to lay all the blame on the 5th vital sign. A lot of folks want to lay all the blame on the Joint Commission for that, and that's not fair, because in the 90s, the 80s and the 90s, there really was the undertreatment of chronic pain. It was a real medical problem. So we have to recognize that that's kind of the backdrop here, a real problem with the treatment of pain. But what we did, instead of really looking at holistic solutions, we sort of transferred principles that were used in hospice for the previous 2 decades and sort of put that on other types of suffering, including chronic pain. We had new high-potency opioids were brought to market. Obviously, Purdue has recently settled for misleading marketing practices around their name brand OxyContin, which is an extended release version of oxycodone, which for those who need chronic pain management is a very effective medication. And so we also got to be careful when we talk about these things about not further stigmatizing chronic pain patients that now are having a really difficult time because of the opioid crisis to get adequate pain relief. But we brought these new high-potency opioids to the market. Prescription opiate abuse and dependence was rising. This was in the 90s. And ultimately, the most recent data we have, hopefully this year we'll get 2018 data. This was published in 2019, which is the most recent. 11 million people misused prescription opioids, 2 million people for the first time. We had almost 50,000 deaths from overdose. We know that number's much higher in more recent years when we get the data. Over 2 million people had an opioid use disorder, and we know that the majority of folks who have an opioid use disorder never get a diagnosis, just like any other SUD. And so we had 2 million that actually had a diagnosis. So that tells us that the prevalence of OUD was more is likely 8 to 10 times that number. Also, nearly 1 million people used heroin. We know that number's over 1 million now. I want you to look at the difference here, just 2017 to 2015 in 2 years. Almost 30,000 deaths were attributed to overdosing on synthetic opioids other than methadone. So this would be fentanyl primarily here and fentanyl analogs. Almost 30,000 in 2017. That was only almost 10,000 in 2015. So a threefold increase in 2 years. And we'll know that number is much higher as well. And so this just really shows you, without reading all the data to you, that we have a growing problem with opioid overdose and death. It takes a couple years to get the statistics from the federal government on the overdoses and the diagnoses and such, but also takes even longer to really compound what the economic costs of that are. And we know the 2013 data, the most recently, $78.5 billion in economic costs, and we know that number is well up over 100 at this time. And so that's from mostly incarceration costs, where in the United States we have historically tried to use the criminal justice system for a response to what is a public health crisis, right? But also lost wages, lost earnings, the economic impact on business. I recently went across the state of Tennessee for the Tennessee Chamber of Commerce, and we talked to business. What can we do to help businesses deal with this, HR departments deal with this in evidence-based ways? And so this really just kind of sums this up for you all, that we are really dealing with a true epidemic, and we know the numbers today are much worse. And so what can we do? You hear this word evidence-based a lot. It's sort of the catch-all catchphrase now. Everybody's website claims evidence-based treatment, evidence-based interventions. They go to PubMed, they find one article that supports whatever they are doing or want to do, and suddenly they're evidence-based. But what does that mean? And what do we need to support? And so there's a really good definition from Sackett that Duke published, where it says that evidence-based practice, so the whole practice, whether it's the interventions, the whole soup to nuts, that a practice that's evidence-based is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual patient. It means integrating individual clinical expertise with the best available external clinical evidence from systematic research. And so what that tells us is that it's more than finding a study, right? I'm all about us reading journals and staying up on studies, but we have to view each study in light of the larger evidence base. And so what does systematic research tell us? The clinical evidence from systematic research, so multiple studies repeated over time that yield the same results in different populations and settings. And we have to do our best to use that evidence, but also it's important that that evidence is interpreted through a clinical lens, someone that has the training, the education, and the legal scope of practice to take the collective evidence and then through their clinical expertise, put it into action. But also it's not evidence-based if we don't have the patient's values and preferences in mind. And that's important from the outset here too. MAT is as evidence-based as you get, and we're going to talk about that in a minute, the use of medications in the treatment of opioid use disorder. But if we have a patient whose values and preferences don't align with using medication, if we have a patient that's a member of the Christian Scientist Church, for example, then this is not going to be even MAT, despite all the evidence, it's not an evidence-based practice if it doesn't align with the patient's value and preferences. And so an evidence-based practice is where all these things interact, where they intersect. And that's when a patient will receive it, because if it's not in line with their values and preferences, it doesn't matter what the evidence says. It's not going to be effective, most likely, for that patient, because they're not going to be open to it. But it's not just the research, it's the collective research viewed through clinical expertise. That's what we're talking about with evidence-based interventions and practices. And that's the lens we've got to have as we go forward in trying to combat this and address the opioid crisis and, quite frankly, the other substance use crises we have in our country in effective ways. And so it's critical that we have that holistic view. All right. So, what if I told you that despite all these numbers that we've seen, that I've showed you so far, that we've got a solution that results in all the things on your screen: a reduction in the use of illicit drugs, criminal activity, needle sharing, reduction in HIV infection rates and transmission, also hepatitis C we can throw in there. It's cost effective. It's not expensive. It's not tens of thousands of dollars. A reduction in commercial sex work, reduction in the number of reports of multiple sex partners, an overall improvement in social health and productivity, an improvement in health conditions, a reduction in suicide, and a reduction in lethal overdose. Most folks would say that's exactly what we need to solve this crisis. Certainly I would, when you just look at, well, yeah, if we had something that does all these things. And the reality is there's those certain words, because of stigma and unconscious bias and preconception, misconceptions, can lead us to not see the evidence. The reality is that we do have this, and so that as part of a comprehensive treatment program, we're going to come back to that word comprehensive, MAT, with methadone and buprenorphine brand names are Suboxone, Subutex, Zubsolv, Bunavail, the new Sublocade injectable. Methadone and buprenorphine particularly are effective treatments for opioid use disorder when measured by all of these things. I pulled two resources there, but you'll be exposed to more later on when we move into talking about residential models, where this is just, again, evidence-based as you get study after study after study, a half century now, especially with methadone and buprenorphine in terms of evidence is coming in a close second. And so what words, what do they conjure up in us, or can we see the evidence, right? And so that's important as we move into this. All right, so, and again, the definition, the way Sam said, the Substance Abuse and Mental Health Services Administration, which is the arm of the Health and Human Services federally that oversees substance use and mental health, defines MAT as a form of pharmacotherapy, so a treatment with a medication, and it refers to any treatment for an SUD that includes a pharmacologic intervention or a medication as part of and there's that word again, comprehensive substance abuse treatment plan with an ultimate goal of the person's recovery with full social function. And we're going to talk towards the end about what does that mean, recovery with full social function. But basically, it's the use of a medication in a comprehensive treatment plan. Comprehensive. So we're not talking about selling prescriptions. We're not talking about selling doses alone. We're talking about a comprehensive, though individualized, a comprehensive treatment plan. And so when utilizing medications, it's critical that patients have access to comprehensive psychosocial support and counseling services. Doesn't mean that patients necessarily need to be forced into it. Doesn't mean that it's one size fits all, but they need access to it, and that can happen in a variety of ways. Patients receiving an MAT exhibit reductions in illicit opioid use that are directly related to the medication dosage. If they're not on the right medication and not on the right dose, like a medication for any other disease, right, it's not going to be effective. So the medication dosage is important. It's got to be individualized and correct, but also the amount of psychosocial counseling based on their individual needs and the period of time that a patient stays in treatment. So we know that longer treatment times yield better results regardless of the modality. It holds true for residential, even without MAT. The longer they're there, the better the outcomes. With MAT, outpatient, inpatient, the longer the treatment, the better the outcomes. And so MAT as an evidence-based practice is significantly more, again, than just providing a prescription of medication. Though some patients may stabilize and stabilize quickly and only need medication maintenance. You know, in the mental health side, when I did some PRN work with the Community Service Board, we had patients that came in and they were stabilized, maybe medication, counseling, whatever, it was individualized. They had access to all those things if they needed it. And then some moved just to med maintenance. And so I'm not saying that they have to have all these things forever, but they've got to have access to it, or we're not talking about an evidence-based practice, because this is a complex disorder that has biological implications, which the medication addresses and normalizes the brain. We're going to talk about that in a minute, but also there's psychological, there's social components. That's why we call it a biopsychosocial. Some would add spiritual to that disorder. And so all these things are important, and it's going to vary by patient and how we individualize it. This is true in residential. This is true in outpatient. And so it helps someone function more normally. It can address many of the changes caused in the brain. Herman Joseph, who was one of the original researchers with Dr. Stoll, Ms. Swander, and Creek, sort of the godparents of MAT, if you will, published a really great paper I commend all of you to look at called, it was specifically about methadone, but it would hold true for buprenorphine as well, called Methadone as Normalizer. It normalizes the brain chemistry. We're not just talking about cravings and withdrawals. A lot of people know that these medicines ward off cravings and they stop physical withdrawals, but a lot of people don't realize that agonist medicines like buprenorphine and methadone, and don't worry, we're going to talk about naltrexone too, actually normalize the brain chemistry. And so it stabilizes that the biological symptoms of the substance use disorder. And then they can access the treatment process, because these medications, buprenorphine, for example, Suboxone, an amazing medication. I see patients recover wonderfully with it. But we know a recent study that was just out last year, is 80.1% of patients that came into outpatient office-based buprenorphine treatment, over 80% had some form of traumatic exposure, severe trauma, 80%. Buprenorphine doesn't treat trauma. Methadone doesn't treat trauma. Naltrexone doesn't treat trauma, right? We know there's a higher prevalence of co-occurring mental disorders among individuals that have substance use disorders. The medicine doesn't treat these things, so it does a lot. And as far as stabilizing the opioid use disorder from the brain's biology, it does the heavy lifting. But that's not the only thing we're talking about with these diseases. And so these medicines can ultimately facilitate the process of recovery. I'm not going to spend a whole lot of time on this. Oh, I see stuff in the box, sorry. Okay, never mind. There's no questions yet. But I do want to hit it because I don't know what varying level of exposure individuals have had. Even if you work and say you provide MAT, maybe you only provide naltrexone. Maybe you work in a program that only dispenses methadone. So what are the differences and similarities here? On the graph, it says naloxone on the bottom, the antagonist, which is also an antagonist, but think of that as saying naltrexone, because naloxone is the overdose reversal drug, name brand Narcan or Advio. Certainly that's important for you to know about, and I commend everyone to be trained in its use right now. But for an antagonist for treatment, naltrexone is the medicine, or name brand Vivitrol is the long-acting extended release. Buprenorphine, again, Suboxone, Subutex, Zubsolv, Bunavail, and then methadone, which has been generic for many years now. But we're talking full agonist, partial, and antagonist. All that means is methadone has a full opioid effect. It has a slow onset of action, so it doesn't punch you hard and fast, but it does fully bind to and stimulate the receptor sites, the opioid receptors in the brain. Buprenorphine is also an agonist, but it's a partial agonist, so it partially stimulates. It has opioid effects, but only partial, so there's a ceiling effect. And so officially that's at 32 milligrams, but we know now that it's likely at a lower amount than that, where it doesn't matter if I gave you 32 or 100 milligrams of buprenorphine, there's a ceiling effect. It's going to plateau. The opioid effects would not continue to increase. And that's why buprenorphine has a higher safety profile and is able to be prescribed in office-based settings or by primary care physicians, where methadone, because of its full agonist effects, which doesn't mean that it doesn't make one medicine better than the other, right? It depends on the patient and their brain chemistry. But methadone can be more dangerous to individuals who aren't opioid tolerant, so it can only be used in specialized programs, which could include a residential program, which we're going to talk about in a minute. And then the naltrexone or an antagonist, all it does is it blocks the receptors. It doesn't mimic an opioid. It's not an opioid agonist. It simply blocks the receptor site. We all have natural chemicals in our brains, endorphins, that they're opioids. They're morphine-like molecules. And so that's why when we say buprenorphine and methadone help normalize the brain chemistry, they actually mimic what our natural endorphins that everyone has. Everyone on this line is opioid dependent, believe it or not. And if your endorphins were suddenly taken away, you would feel really bad. But an antagonist simply blocks but doesn't normalize the brain chemistry. So that's an important point we're going to talk about in a minute. Okay. So again, methadone, it reduces cravings and it activates receptors in the brain, but it produces a tolerance. So the body gets used to the medication. So you are physically dependent, but again, an opioid use disorder versus an opioid dependence, two different things, right? Opioid use disorder, we're talking about increasing need of opioids, continued use despite wanting to stop, continued use despite catastrophic consequences. There's a whole list of diagnostic criteria in the DSM. And, excuse me, physical dependence alone does not equal an opioid use disorder, because patients who are properly stabilized and in treatment, they're not stealing checks out of granny's purse anymore. They're not popping off fake prescriptions. They're not potentially engaging in risky behaviors to get money to feed their habit. And so we're talking about dependence here, but the physiological tolerance that methadone produces can actually help protect someone against an overdose. Although it's not a blocker itself, the tolerance alone can help patients be protected against an overdose. And it's long acting, and that's one of the reasons the FDA approved it back in the 70s. You can take it once a day in most patients. These are generalizations. Some patients have rapid metabolisms and need it twice, but you can take it once a day, and then you can go about your day living normally. Same thing with buprenorphine or buprenorphine/naloxone. So what's up with this naloxone and these buprenorphine? You see Suboxone's buprenorphine and naloxone. Zubsolv, buprenorphine and naloxone. Dunivel, same thing. Excuse me just a second.
Zach?
Yeah.
Hey, this is Jess, the moderator, and I received a question that I wanted to pass along to you.
Awesome, thank you.
The question has to do with what the rest of the presentation will address, and he says, will you be addressing the barriers associated with methadone on the DEA level, like storage, adjustments, and disposal for rural inpatient sites that are not methadone dispensary locations?
Yes, so yes, the short answer to that is yes. I mean, I won't go into the exact, very specific things there. But yes, we're going to talk about all three medicines in an inpatient setting, which is one of our objectives, and how you can utilize them either by MOU with existing providers, or if there's not one, how can you utilize medications that require dispensary? So yes, that will be covered.
Great, thank you.
You're welcome. And so again, same thing as largely methadone, we're talking once a day, but the higher safety profile. The naloxone, one important thing here is that the reason that's there is the theory behind it is if when you take these medicines properly, Zubsolv or Suboxone under the tongue, Bunivel goes in the cheek, as directed, the naloxone is not absorbed. And so the theory is if you inject it or abuse it, the naloxone would activate and send someone into withdrawal. So the naloxone is only there as an IV deterrent. It doesn't have any treatment properties per se. All right. This is one example of a study that shows when the control group versus a blinded buprenorphine group, when the treatment retention, because treatment doesn't help if they don't stay in it. This simply shows the controls drop out, those that were on buprenorphine stay. So it does drive retention. Like we talked about earlier, naltrexone is a blocker alone. It can be administered by an injection once a month and prevents the binding to the receptors. So again, we want to restore physiology, promote rehabilitation, reduce the signs and symptoms of withdrawal, reduce or eliminate craving, and block the effects of alcohol or opioids. Naltrexone or Vivitrol, which is the name brand for the injectable extended release, is one of the only meds, certainly the only injectable extended release that's approved for both alcohol and opioid use disorder. And so when you're looking at folks that may have co-occurring disorders. So what are clinical barriers to implementation, especially in traditional residential programs? A lot of it, one of the barriers that are encountered are treatment ideology. Traditional 12-step model treatment programs are less likely to adopt, historically have been less likely to adopt MAT medications, and some have even discouraged the use of medications. So that can be a barrier. Provider access, prescribing clinicians not accessible or unwilling to prescribe, and I think that's going to piggyback on what the other question we just had was about rural areas. Or what if you don't have an X-waivered physician that's able to prescribe buprenorphine? Many that have their X-waiver are unable or unwilling, rather, to prescribe. Many don't see any patients, which is why this notion that suddenly removing the X-waiver would lead to mass physicians treating people is just not borne out by the facts when those with X-waivers won't. So we're talking about stigma here, or people that just aren't accessible in some communities. Some of the clinical staff or the traditional alcohol and drug counselors have been trained, especially those that have been in the field a long time, in abstinence-based model that views medication as substituting one drug for another. Some of it is just the staff members haven't been trained, right? They don't teach this stuff in medical school. They're starting to. Brown University Medical School, just a really cool article came out there training all their physicians in it, and some others as well. But they might just need to be trained, and then the senior clinical staff members are often in a position to train new staff, and so it's critical that we make sure they have the evidence about multiple pathways to recovery. So I think we need to make it clear that this is, when we're talking about bringing this into more traditional residential programs or even non-traditional residential programs, that the role of self-help programs, this is not an either or. But we need to really consider, when we're talking about the 12-step programs, which dominate most residential programs, what are the official position of those versus the opinion of members, right? And so it's been a long-held 12-step policy of members should not give medical advice to each other. And so it's important to acknowledge many people require both tools, whether it's 12 steps or other peer recovery support programs like SMART Recovery, MARA, there's a lot of others, and a medication to assist that recovery. Bill White, one of the lions of our field, this is a quote from him that I think is really applicable as we consider bringing MAT into these continuums where they haven't historically been. When he said, the guiding vision of our work must be to create a city and a world in which people with a history of alcohol or drug problems, people in recovery, and people at risk for these problems are valued and treated with dignity, and where stigma, accompanying attitudes, discrimination, and other barriers to recovery are eliminated. So again, if we go back to that definition of an evidence-based practice, what does that mean? I'm going to blow through this real quick because I've kind of said a lot of this earlier. But like most conditions, we could treat opioid use disorder before we understood it, but now we know why meds work, and we know that this is a treatable disease. Like we talked about earlier, this is a chronic brain disorder, but it's expressed through behavior within a social context. It's that biopsychosocial. It's complex. It's about more than meds. But it appears, because it's expressed through behavior, that someone's doing it to themselves, right? It's been misunderstood. Our drug policy in the United States, we've got to own the fact that we have a shameful and racist history, and our drug policy bears that out more than anywhere else. Victims are criminalized. We use the criminal justice system to address what's a health crisis. They're dehumanized, right? That's just a junkie. We dehumanize individuals, and so it makes it hard for us to see it as a disorder when we see people in this light. And it's important to remember, a little over 100 years ago, we thought psychosis was possession by demons. And so, just in 1-2 generations, our grandparents would have been around at a time that was common thing, and so common thought. So again, not going into a lot of depth here, but you have your biology and genes that can make you predisposed, but it's environmental, it's psychosocial. Okay.
Hey, Zach, I've gotten.
Yeah, I'm trying to see where are the questions.
Some of them get sent directly to the host, so they're not visible to you.
Yeah, go ahead and read them then. We'll make it work.
Okay, let's make it work. So the first is a question about methadone and how it impacts patients.
Okay.
This question says, can methadone cause confusion and short-term memory issues when used either long-term or short-term?
No, when methadone is used properly, knowing all medications can be abused, right? But the risk-benefit, when methadone is used properly in stable maintenance treatment, the answer to that is no, absolutely not. There's no evidence that supports that. In fact, the individual that's presenting to you today is in recovery because of methadone treatment and many years of it prior to getting to you all today. And so whether people can taper or whether people need it long-term, many can taper. That's just not borne out by the facts. In fact, I completed graduate school by taking methadone. But that's a subjective experience. But the important thing is the objective data. There's no data that supports that. Mm-hmm. So that is not a fear. But methadone, because it's a full agonist, when it's mixed with other things, we have to be careful, benzos, especially Xanax, Valium. And so it may appear that someone's having issues, but I would want to know, it's more likely that the impacts on the brain prior to treatment and recovery could have caused some of that stuff, or are they mixing it with other stuff and it's appearing that they're having some impairment like that. But methadone by itself, when used properly, the answer is no.
Okay. I see 2 more questions.
Yep.
The first one really piggybacks on that. It says,
right.
Do buprenorphine and methadone help normalize brain chemistry only while the patient is using the medication, or do these medications help stabilize the brain when they transition off of it as well?
So that's a great question, and I would ask if I could kick that because I'm about to actually cover that here in just a second as to how it stabilizes during maintenance, and for those that can taper, what's going on in the brain during the tapering.
Okay, fantastic. This question also, I think you will get to some of it later on in your presentation. So I'll just pass it along to you and you can address it whenever it makes most sense. It says, we are interested in and open to doing MAT. Our barrier has been that we want to integrate it into our current outpatient evidence-based treatment models, not create a standalone MAT clinic. Is there guidance on how to integrate MAT into those services?
Okay, that's a great question. And yes, I will. I'm going to write down and make sure I specifically address that, but I'm going to get to that for sure. And we'll talk about the integration, whether in outpatient programs that aren't utilizing it, as well as residential programs. So yes, we'll get to that. That's good. I'm making a note, though, to make sure we hit that specifically. Okay, good.
Thank you.
Great. I'm glad people are responding so we can drive this in the right way. So we're actually going to hit the maintenance versus tapering and the normalizing of the brain here in just a minute. But first, we talk about science come a long way. I'm sure if we were all together, I would ask people to raise their hand and how many folks have seen this before. But, our perceptions of substance use have changed, but science has come a really long way in helping us understand how drugs of use affect the brain. And so this is one, I'm not going to hit you with a bunch of brain slides, I promise. This is not a neurophysiology lecture, and I want to get more into the meat and potatoes of integrating into residential and outpatient here in just a moment. But I do want to show you this because this is the kind of stuff a lot of folks just haven't seen. These are PET scans. Obviously, we've got 3 brains here. The first being your control brain or your, quote, normal brain. The middle brain is a brain with opioid use disorder that's on agonist therapy. And so this brain in particular is a brain that's on methadone. It would be similar with buprenorphine. And then this one, the last brain is a brain that's got opioid use disorder that's in sustained remission. And so this is your non-MAT brain. your traditional approach, perhaps, residential, then 90 meetings in 90 days, and so on. Both brains are in recovery and have been free from illicit substance use for the same period of time. Control brain, no substance use. What I want you to pay attention to is where these arrows are up here, the red, okay? And we can tell a lot by measuring glucose metabolism in the brain. That's the food for the brain and how the brain uses it and processes it. And so the red is what's important here. We're not going to get into the weeds, but I want you to look at the red on the first brain, especially in the middle frontal here, and on this one, there's a little bit more, but not a whole lot. And this one, you see just how huge, how much larger the red is, especially in this entire frontal area. And so what does this mean? Why are you showing me this? This last brain here, the brain that's not using medication-assisted treatment, because remember, we're talking about normalizing the physiology. This is a brain over here on the right, is a brain in stress. That's a brain on the verge of relapse. And so it really gives a window into why individuals with an opioid use disorder, when an MAT is not utilized, the relapse rates are upwards of 90%. But now we don't want to get in this forcing all people into MAT either, right? Because it's about patient values and preferences. And for the 10% that can recover or so without it, that's great. So we need to support all options that offer help and hope. But this is just the evidence. And so the brain that's on agonist therapy in the middle here is closer to normal. It's a healthier brain. And we know that eventually, over time, most individuals, realizing the biological and genetic components, but that most individuals over long periods of time, the non-MAT brain could eventually normalize as well. The problem is keeping people alive long enough for that to happen, and also so they can have a quality life, right? We want people to have a quality life and not be miserable. And so this is what we're talking about. We're talking about, you can actually see it on these PET scans, how MAT can help normalize the brain. And so we talked about endorphins already, but they're important in maintaining the body's normalcy, right? A lot of things that is involved in pain, pleasure. And so when these opioids come in, these brain chemicals, and I told y'all earlier, we all have these natural endorphins, and this is going to kind of launch into answering that question about normalizing the brain and maintenance versus tapering here, and why this is important, that even if we're talking about a residential program here in a minute, MAT may need to continue post-residential treatment. That, if you think about many years ago and you're running away from someone that's going to kill you, or a lion's going to eat you, and you break your toe, you don't feel the toe because a lot of things happen. When you break it, endorphins rush, dopamine's released, fight or flight, all these chemical things. Now, later on, the toe's going to hurt really bad when you're calmed back down. So endorphins are a part of this natural system. Endorphins are also released and play a role in both male and female orgasm, right? Propagation of the species. They're a part of why sex is pleasurable. The runner's high. That's why you feel good after you exercise. You did something good for yourself, you get a little bit of reward. So they're involved in the reward system of the brain. And we all have these natural opiates. So what happens over time is, if you think of it like a lock and a key, the key are the opiates. We all have these natural endorphins, and we have the receptors, the lock and the key. These are the two main sides. I'm not going to get in the weeds, but the two main sides of the opioid peptide system and the opioid ligand system in the brain. And if we're constantly flooding the brain with outside keys, opiates from the outside, a couple things happen. The brain realizes there's all these keys, and so it can actually impact the production of your endorphins. And that can lower, that can be completely stopped. There's also some stuff now that suggests some people that have a propensity, the biology, to develop an OUD, maybe they never had normal levels of endorphins to begin with, and that's why they finally feel normal. So there's a lot of things there that as we hit the brain with outside opiates, keys from the outside, the brain's like, I don't need all the keys that I make anymore. And so the endorphin production is actually affected and can even shut down completely nearly in some patients or some individuals. On the other side, you have the lock. So if the key goes in the lock, it's got to fit perfect, it turns, and then all the other things happen, the dopamine and all the reward, the high. But what happens is as we have more and more keys come into the brain needs to lay down more and more receptor sites because it has more keys to accommodate. And so over time, it takes more keys and more opioids to fill those receptor sites to try to get the same effect. At the same time, that backside where the dopamine's released, all the chemicals, eventually that gets out of whack. And so you have this whole system in the brain where your natural keys, your natural opiates are kind of shut down or not producing at normal levels, maybe not at all. And your receptor sites, you have all these receptor sites. But what happens with the short-acting opiates is you're high and then you're in withdrawals. You're high and then you're in withdrawals. You're never really in that normal range. And so the opiates, the natural opiates, endorphins we have a really gradual onset, bind, and slowly fade away. There's not that rush. You might feel some rush from the dopamine and stuff, but by and large, endorphins are involved in your ongoing day-to-day brain chemistry. So both sides get damaged, and this goes into the maintenance versus tapering. So you're going from being high to in withdrawals, right? And so the brain's saying, I need more locks. I need more receptors. Then you're in withdrawals. Wait, I don't need as many. And so the brain's constantly flipping back and forth between thinking it needs more receptors, less receptors. The literature refers to it as though the receptor sites in the brain become deranged, damaged. So during maintenance, because methadone and buprenorphine mimic these natural endorphins, if it's the dose is right, a slow onset of action, there's not the highs, the peaks, and the valleys. It lasts all day. It mimics the endorphin. We're talking about endorphin replacement therapy here. And that's why it's not trading one drug for another. That's why it's really different. But those receptor sites, the locks, during the maintenance period can begin to heal, can begin to stabilize. The deranged receptor sites can begin to repair, and you normalize that part of the brain during maintenance. Then for those that are ready, able, and want to taper, as you slowly lower the dose, little bits at a time, on the methadone side, they say no more than 10% of the dose total, so not milligrams, percent. So at 100 milligrams, you can drop by 10, but at 10 milligrams, we're talking a milligram at a time. No more than 10% of the dose, no more often than every 2 to 3 weeks. A month is better, 2 months is even better, right? Because we know longer treatment times yield better results, and the longer we allow the brain to heal. So as we're bringing the amount of keys down, okay, as we're bringing the amount of opiates down, the endorphins, the goal is to go slow enough that the individual doesn't feel it. And as you take a little bit of the methadone or the buprenorphine away, you give it enough time that the brain can kind of replace it, and that natural opioid system can kick in again and replace it with endorphins. So as you remove a little medicine, you got to give it time for the endorphins to take over. Then you remove a little more, and slowly, as you gradually decrease the medication, the natural production of endorphins and natural opiates begins to take over again. And that's why you got to go slow. You got to do it over a long period of time because it actually allows the natural endorphin system to take over. Now, the thing is, we talked earlier about some evidence now shows maybe some people never had enough endorphins, right? Or some people, maybe because of the length of use, the damage, though their brain might be able to start producing some endorphins and such again, maybe not ever fully take back over. And so for some people, if quality of life is the measure and normal brain chemistry is the measure, may need indefinite maintenance. But many patients can, as long as you stay in maintenance long enough, and the National Institute on Drug Abuse says, 1 to 2 years minimum. Most people need much longer to allow that receptor site part of the brain to heal. Then as you slowly taper the meds, you allow the endorphin production to take back over. So the answer is, to the question, do the medications allow the normalizing of brain chemistry during tapering? The medications, if used properly, help restore normal physiology, both during maintenance and tapering. But we have to recognize that though many people can, if they've had comprehensive services and they've been free from other drugs, can taper if we go slow enough and over a long enough period of time, that not everyone can. And so the goal is we want normal balance. What would be going on in a normal brain with endorphins and receptors and all of that? And we normalize that, just like we do with the diabetic pancreas. The pancreas isn't producing natural insulin, so we give a synthetic version so the body can function normally. Some folks with diabetes can change their diet, their lifestyle, exercise, and not be dependent on insulin. Others, no matter what, will likely be insulin dependent the rest of their lives. And it's similar. We're talking both diabetes, asthma, as well as opioid use disorder. We're talking about chronic metabolic disorders. So that's the answer to that question. Okay. Let me check my time because I want to make sure and get into the residential. Okay, we're good. So again, this talks more, just another example of what we're talking about. But it's a complex medical condition. It takes time to understand it, y'all, and we're just on the tip of the iceberg of all this information and research. We know these medicines work. We've got overwhelming evidence, especially with methadone. It's probably the most evidence-based treatment in medicine other than maybe statins. And advances in neuroscience have helped move things forward, and they're going to continue to help move things forward. But we know why these two medicines in particular work, because they normalize a deranged brain chemistry, and if used properly, even during the tapering. And so that's why the literature shows many people need medicines for long periods of time. Even the people like myself that were able to slowly taper. It took years. It took me as long to taper as I stayed in maintenance. And some people can't taper. And that is okay, because what matters is a patient's life and their quality of life, not whether or not they take a medication, right? So they're not a substitute, but a medication that normalizes a system that has been damaged by drug use. It's not about their willpower, their motivation, it's about their brain chemistry. So the evidence real quick, there was a literature review that was published in Psychiatric Services in 2013, and it looked at all the history back at that point, right at 50 years just about, a little over, about methadone effectiveness. And after the literature review, the authors conclude, overall, there is a high level of evidence for the effectiveness of methadone maintenance treatment and improving treatment retention and decreasing illicit opioid use. The same publication the following year in 2014, some other authors did a literature review, buprenorphine effectiveness we had to date, and the conclusion was overall a high level of evidence was found for the effectiveness of buprenorphine maintenance treatment and improving treatment retention and decreasing illicit opioid use. And so again, we're talking with methadone and buprenorphine particularly, when used properly, and patients have access to comprehensive services in line with patient values and preferences and clinical expertise. It's the textbook definition of an evidence-based practice. And so I want to talk, and so back, let me say before because that's methadone and buprenorphine. Naltrexone is a blocker. And so the naltrexone, unlike methadone and buprenorphine, will not mimic the natural endorphins in the brain. It just doesn't. It blocks them. And so it's a different approach that does work for some people. Dr. Dole, who was one of the godfathers of the original researchers, because we've used oral naltrexone for opiate use disorder since the 80s. A lot of folks don't know that, but patients would just quit taking it and get high. They could just not take it. So people just didn't stay on it. A lot of patients complained it didn't make them feel good. So we have a lot of success stories now with an extended-release injectable naltrexone, but it's a different specialized population. We have to consider in some patients, if it blocks the synthetic opiates, if they use, could it also be blocking the natural endorphins? And so people that have a higher propensity of depression, hypersensitivity to pain, naltrexone may not be the right approach for them. So naltrexone blocks the high, blocks the euphoria, but similarly does not normalize the brain chemistry in the same way. So it could be appropriate. We've seen it used effectively in outpatient OTPs post-taper methadone or buprenorphine. Someone may want to transition to naltrexone for a short period of time as they transition to a medication-free state of recovery. After someone's been in a criminal justice system and not used anything for some months, as they continue to receive outpatient care. So I'm for all the tools in the toolbox, but I just want to point out why buprenorphine and methadone are kind of talked about here differently, and naltrexone is not included because they do different things to the brain and they're a different approach. So again, now we'll kind of get into the meat and potatoes of integrating MAT and traditional residential programs. But first, I want to stop and see if there's any questions, any other questions that have come in that we need to address.
There are a couple of questions, and this one I've heard before, and I wonder if you have as well. It says, does methadone cause dental issues like crystal meth does?
So, no. What methadone itself does not know. So there's a couple things at play there. That's a very common myth. What's going on is all opioids, methadone, any opioid can cause dry mouth in some patients. Dry mouth, as you can ask your dentist, can cause dental problems if you don't watch it. And so if patients that are taking methadone, same thing can happen with buprenorphine though, because it has opioid effects too, remember. It just doesn't quite share the same stigma as methadone. And so the dry mouth could cause it. Also, we think about a lot of people when they come into treatment. I can tell you years ago before I was in recovery, I didn't pay attention. I wasn't going to the dentist every 6 months. I wasn't going every year. Hell, I wasn't going every 2 years. And some days I brushed my teeth. Some days I probably didn't. It depended on how I felt and if I had pills, I'm sure. But I didn't pay a lot of attention to my dental health just like I did in my other health. And so when patients come into treatment and they start stabilizing and doing well, suddenly all those years of use catch up with them, and they go to the dentist and they realize they've got problems and cavities. And it's easy then to say, oh, since I started methadone, I've had all these cavities. Well, maybe that's because for the 10 years prior, you didn't go to the dentist. And so, you know, we have to really look at these things in context and how some of these things have developed. But it is true that all opioids, of which methadone is one, can lead to dry mouth in some patients, but things like Biotin and some of those things make it easy to address. But by and large, it's because of the unhealthy practices prior to treatment that start catching up with people when they finally start paying attention to their health. What else we got?
The next question we have here is, why does a nurse practitioner have a patient limit on the people we can treat with buprenorphine? This says, I can write pain medication for hundreds of patients for only 75 patients for Suboxone. I have many patients on benzos, and there's no limit to these patients to get care.
Well, that's true, and I would say we're currently in an opioid crisis with a rising benzo crisis, facilitated at least in part by the unregulated prescribing of opioids. So I don't know that that's a standard we want to hold out. That said, the X waiver and the patient limits can be a barrier. I see it every day, overseeing 7 office-based programs where we utilize NPs and PA and physician assistants and physicians, psychiatrists and general practitioners that are X-waivered. And so I think that conversation, we've got to be real careful, because certainly we don't want to use the unrestricted prescribing of opiates that got us here as our standard for treatment, because the last thing we need are buprenorphine mills to replace the pill mills. The good news is buprenorphine has such a high safety profile that this is not excusing diversion, but the reality is the vast majority of diverted buprenorphine are going to people that need to be in treatment. And if we addressed our access issues, that would probably do more to address diversion than anything else. And at least buprenorphine's not killing people, right? It's actually probably keeping them alive. That said, diversion's a real problem. There's this notion now about therapeutic diversion, which makes my head explode, because I can acknowledge it's keeping people alive and it's probably going to people that need treatment, but there's nothing therapeutic about somebody getting a felony drug charge for possession of a Schedule III that follows them the rest of their life when they're in recovery and want to go to school or when they want to get a job. And so there's nothing therapeutic about diversion. But, you know, the X waiver, it's not just nurse practitioners. Obviously, physicians are the same. The good news is with the SUPPORT Act, nurse practitioners and physician assistants that are working in qualified practice settings where you have patients have access to those comprehensive services that I'm talking about, like ReVIDA, we're considered qualified practice settings. Nurse practitioners can apply easily and go up to 275 pretty much right away. And so, and I'll tell you, I have a lot of full-time NPs and physicians that work for us, and many have their 275 slots, and our full-time physicians, not a one of them is at capacity. They're close, some of them, within 15 or so. And they're full. They have no appointments if we're doing all this the right way. So if we can get up to 275, I've not seen evidence overseeing 7 OBOTs with full-time physicians and NPs that we need more than that. But I think an argument could be made in a qualified practice setting, especially with telehealth and other things, that we could go higher. But do we want to get rid of it completely? I don't know. That's another conversation. It makes me nervous to remove any training because we already know medical schools, nursing schools, schools of social work aren't teaching what we're talking about today. And then we're just going to turn you loose to deal with an already vulnerable population. That makes me nervous. And so I think that's a larger discussion there. But under the Support Act, if you're in a qualified practice setting as an NP, PA, or physician, you can pretty much skip the 100 patients and go straight to 275. And if you are full, at that, then, that's a larger policy conversation. But the reason for that is, it's a multifaceted reason as how we got there. That legislation was drafted in 2000 and amended later. Mm-hmm. And we originally thought that thousands of primary care physicians across the country would all treat a handful of patients. We never envisioned people doing this full time as buprenorphine prescribing. And so that's really, I guess, where I'm going to leave that. But it's a good question, and it's an ongoing policy debate in the field.
Mm-hmm. All right, we've got a handful more questions about the 3 MAT options.
Sure.
One question has to do with tapering. And this person says they understand that the reduction should be gradual, but it still may trigger strong cravings. And so they say, is buprenorphine a safer option than methadone if tapering off is the client's preference?
I don't know that there's any, when we're talking about tapering, safer is not really the discussion to have because we're talking about removing the medication. And so the risk of relapse is there and overdose for both. If patients are having really strong cravings, though, and or withdrawals, mm-hmm. the clinical evidence that brings to me as part, and knowing that I am not a physician, disclaimer, okay, but on the larger multidisciplinary team, if I'm sitting at a table and we hear that, I know the first thing I'm going to hear my medical director say is, well, then you're going too fast. You've dropped about too much at a time, and or maybe that patient shouldn't be tapering yet. And so when tapering is done properly, and that's why informed consent of the patient is so important, that we understand all this, because we have to help our patients understand it, because they come into treatment with all the stigma, all the misconceptions that are in the larger society. And so we have to educate them so that they understand. I have patients come in all the time, now I want to stay as low as possible and then get off as quick as I can. I say, okay, if that's really what you want to do, we'll talk to the doctor. It's the doctor's call and your call. But you've got it's informed consent to treatment. And when the patients really understand it, it's empowering to them because then they realize it's not about their willpower. It's about their brain chemistry and how the medicines work. So if they're having significant cravings and taperings, it's not about safer methadone or buprenorphine. Methadone, you can actually go, despite being a full agonist, by lower increments. You can go down to 1 milligram on the liquid. And it's been historically, from my subjective experience, for patients that taper, it's been easier and fewer symptoms for us to taper people off methadone. And I think part of that is there's a lot of physiology there and that we won't go into, but buprenorphine has a stronger grip on the receptors. I think that might be part of it. But more than anything, I think it's because we can only divide a strip or a pill down by so much. But both can be done, but you just, you need to, if they're having that many cravings, you maybe went by too much, or if you're going by the smallest increments possible, they need to hold longer in between. It's also worth considering, what if they're one of these folks that just, the physiology of the brain is not normalized? Why would a patient be so why would they be so motivated to taper if it meant they were tapering themselves into misery? Mm-hmm. And so, getting the patients, we have an obligation to help them understand that this is about their quality of life. Mm-hmm. And whether they taper or not, that they're in recovery, which we're going to talk about in a minute. What else we got?
Does naltrexone reduce cravings for alcohol as well as being a blocker for opiates?
I knew this question was going to occur. So there is some objective data that naltrexone, both that it can reduce cravings for alcohol use disorder. It's also a blocker for alcohol, not just opiates. On the opiate side, there is some subjective data and suggestions by the drug company that Vivitrol or naltrexone reduces cravings for opiates, but there's not any objective data I've found from a study that hasn't been funded by the drug company with a patent. But it certainly serves as a blocker. I've known some patients that have done miserably on Vivitrol, but did great on bup and or methadone. I've known other patients that never felt right on an agonist and did great on Vivitrol. And I think it's just like any other medical condition. One, like I said, we still don't understand it all, y'all. We know what we know, and we know why methadone and buprenorphine have better overall long-term outcomes because we understand how they normalize the brain now. But we still don't know everything there is to know about these medications.
Okay.
All right, what else?
It has to do with impairment. So is a person considered to be impaired while using the medication Suboxone and methadone? And if so, how can a person fulfill their daily obligations, such as working, driving, etc.?
So this is a good question. So when these medicines are used normally, you're not any more impaired than everyone on this webinar is impaired by their natural endorphins, right? We just talked about that. They mimic the natural endorphins when they're dosed properly. Now, if they're mixed with other substances like benzodiazepines, Xanax, Valium, alcohol, yeah, you can become impaired. But these medications alone don't. If there was overwhelming evidence of that, which there's not, there's actually overwhelming evidence in studies of the psychomotor functioning of methadone and buprenorphine patients that on stable doses it's a normalizing. But if there was impairment, I mean, it wouldn't be legal for patients to drive to these outpatient programs, right, to receive this medication and go home. And so the answer to that is no. When it is used properly and it's the only medication you take, it is normalizing, not impairing.
Okay. Is there an optimal wait time for transitioning between methadone and naltrexone?
Oh, okay. That's a good question. So like post-taper, I assume, is the direction of that question, like what I mentioned earlier. You know, with short-acting opioids, before you start naltrexone, you want to, and again, y'all, a trained physician needs to make these final calls. I'm talking in generalizations here. But, because these are all medical decisions that we're talking about with these medicines. But, you know, for short-acting opiates, which methadone is a long-acting opioid, you're going to want to wait, you know, the recommendation to start naltrexone is a full, 3 days. With a longer-acting opioid, you're looking at more 7 to 10 days, if not 2 weeks post last dose. A lot of folks do, and what my physicians that I've worked with that have used naltrexone have always done is we do the oral naltrexone first because you're not committing them to 30 days. So if they're not quite ready and you give them an oral dose, it's, we're committing them to 1 day versus 30 days. And so and we're going to talk about a little bit again about oral naltrexone in controlled environments like residential programs here in a moment. But, you do an oral test. Some people are even using naloxone oral naloxone to do an oral test before starting them on naltrexone. And so, but you're looking at 1 to 2 weeks. But again, how much methadone were they on? Did they taper all the way down to 1 milligram and then come off? Those things. And so really an addiction medicine physician that's knowledgeable in this area has got to make that call based on the individual patient's history.
So do you want to, we still have a couple other questions and they're still coming in, but do you want to move forward?
You want to move on? Yeah, I'll move forward and I'm kind of watching the clock. Yeah, sure. Okay. So let's talk residential. Y'all keep the questions. I'll address as many as I can, and I'll try to leave room. I want to point out these 2 manuals really quick. Tip 43, I don't even know if you can get it anymore. It's certainly not published, but you can find a PDF if you search for it. I think it's off the SAMHSA website. The reason I feel like it is, it's got DSM-4 and it needed to be updated, but it's got a lot of the comprehensive stuff in it about the counseling and stuff that TIP 63 doesn't have as much in, especially when it comes to comprehensive OTPs. The TIP 63 you can definitely get. It's your tax money at work. They're free. You can go to store, S-T-O-R-E, like the grocery store, store.samhsa, which is spelled there on your screen, S-A-M-H-S-A, store.samhsa.gov, and order TIP 63. It's your manual of the evidence base for all medications for OUD. You can get a PDF. They'll mail you a real fancy glossy paper version at your tax dollars at work. Use these. Get these. Understand these. It also has a lot of stuff. Be sure and get the full version, not just the executive summary, because it talks to addiction professionals, policymakers, patients, families. It's got a lot of great stuff in there and tips that will address a lot of the questions you're asking. I love having the discussion, but if you think of something later, this is your go-to. So tip 63, tip 43. Hazleton Betty Ford Foundation, I want to talk real quick about what they did, what they've discovered, and then what my colleagues there kind of are reporting back to us now. They started this Core 12 where, Hazleton Betty Ford is a more traditional residential-based program, historically no medications, 12-step based. And they started seeing in 2012, we talked about the etiology of the opioid epidemic early on. They started seeing a high incidence of death shortly after treatment from individuals that had an opioid use disorder and an overall increased patient population with opioid use disorder. We looked at those numbers of the epidemic at the beginning of the webinar, right? They're people that are diagnosed and dealing with and using opioids is growing. And so they created a steering committee that involved clinical, medical, communication, research folks, and ultimately altered their entire treatment for opiate use disorder. And what they did, because they still believed in the value of the steps, that's their model. If you go there, that's what you're going for and that's what you want. So they didn't abandon their foundation and philosophy there, but they integrated medication-assisted treatment in there with 12-step facilitation. They originally developed 3 distinct pathways, but they include access to those comprehensive service we talked about that includes recovery coaching for some if they needed intensive outpatient programming after the residential and or therapy. And so what they saw, excuse me, this was the increased admissions for OUD between 01 over that 10-year period. Adults from 20% to 30%, so, a third increase. But you see the youth really skyrocketed there over that 10-year period for them. And so they had a significant rate before the MAT with people leaving against medical advice that had opiate use disorder. They feel miserable, they're not functioning normally, and they're out of there. They want to get well. And so the risk for that is that nearly all patients with an opioid use disorder leave treatment to relapse. And now, especially now, even more so than back when they were first starting this, relapse could mean death because, there's areas of Western North Carolina. I was talking to the harm reduction folks at the, North Carolina Survivors Union, and they do testing, of the heroin supply and all that in the area. And they said in Western North Carolina, heroin pretty much doesn't exist anymore. It's pretty much all fentanyl. And it's just a matter of how potent the fentanyl is you get. And so relapse now could mean death, y'all. They saw people that used opioids during treatment. People that had opioid use disorder were more likely to do it into the people that had an opioid use disorder were more likely to have an incident of death following treatment overlaps. They were more likely to smuggle in opioids or attempt to. And so they really felt that they had an ethical imperative to evaluate their treatment models, which is why I'm sure a lot of you all are on here today. And just they had to realize that opioid use disorder is not like other substance use disorders. And so the challenges of treating folks with OUD are significant because these intense cravings, the ongoing stress and anger, heightened impulsivity, those are all common symptoms of folks with opiate use disorder that can be disruptive to the treatment milieu. It can undermine the individual's ability to engage in treatment. Again, it's not their fault, it's about their brain chemistry. How do you engage in treatment when you feel like death? And it causes them to leave prematurely, which then puts them at risk of accidental overdose. when they return to pre-treatment levels of use. And so they followed the evidence about what works. And they came with medication-assisted treatment. They particularly looked at incorporating buprenorphine, or trade name Suboxone, and naltrexone, or the extended-release trade name Vivitrol, in addition to and not as a replacement for their historic clinical interventions. And we're going to talk here in a minute about methadone as well, although Hazelden doesn't use it. And it really required a cultural shift within a larger abstinence-based organization, and that's what many folks are up against. I did some technical assistance for Bradford Health Services in Alabama when they were implementing MAT into their continuum. Some great folks, but they're dealing with that cultural shift within the organization. And so they really needed specific procedures in place to prevent diversion and abuse. And again, you all, SAMHSA has technical assistance money out there. You don't have to be a not-for-profit. You can apply to get TA from SAMHSA. The ATTC does some depending on your region. And they'll help you with the development of some of these policies, with some of the programming around best practices and regulations. You're not all on your own, and you don't have to get all your answers today. You can get TA for this stuff. Again, tax dollars at work. But these folks needed psychosocial therapies in place. Well, what they discovered is they needed therapies in place specifically for those using opioids, because different types of interventions work there. And then ultimately the goal became full engagement and extended treatment, long-term recovery. And at first, there was still had a big focus really on eventual medication tapering to abstinence. And if we borrow from the 12 steps and 12 traditions here when we're talking about MAT, Tradition 3 of AA says the only requirement for AA membership is a desire to stop drinking, and NA a desire to stop using. And from an AA publication, it says nothing seems so fragile, so easily breakable as an AA group. Every AA group had membership rules. And so a tradition of group autonomy can drive people to have different rules. And this 12 by 12 was specifically referencing the use of medications. And it says the answer now seen in Tradition 3 was simplicity itself, right? At last experience taught us that to take away any alcoholic's full chance was sometimes to pronounce his death sentence, and often to condemn him to endless misery. And so who dared to be judge, jury, and executioner of his own sick brother? And if we borrow from that tradition, the only requirement is the desire to stop using. And if we take away their full chance, that could be to pronounce their death sentence. And for some, as we know, 90%, if we don't give them MAT, they relapse, and now relapse could mean death. And so from the traditions themselves, who dared to be judge, jury, and executioner of his own sick brother? So we're not talking about something that's contradictory to those traditional things. We've already talked about buprenorphine, so I'm going to skip over this. And so what they really came up with, and I'm not going into a lot of depth, but I'm going to show you a manual if you want to learn more about Hazelden's program, is everyone that comes in, there's kind of these pathways. People, week 1 are given Suboxone no matter what. Then there's 3, they can stay on Suboxone and do a gradual taper to no medicines. What we know is the long-term outcomes there of that first top line end up being not much better than no treatment or no MAT. The middle line, Suboxone in week 1, and then they optimize the dose, they stabilize the dose. That's what we were talking about earlier, where you stabilize and normalize the brain chemistry. Week 4 and beyond, then they stay on Suboxone. Now, down the road, many might be able to taper. And so when we're talking about maintenance, that could also include tapering eventually. Maintenance just simply means that it is treatment with a medication under the federal rules that lasts longer than 180 days. So it doesn't mean that you're in indefinite maintenance, although some may need that. It simply means that it's longer than 6 months. And then the other path they had that kind of went over to the extended release injectable naltrexone or Vivitrol is they would do Suboxone in week 1 and then do a Suboxone taper, switch over to a low dose, again, that oral naltrexone first, like we talked about earlier, then move them over to the Vivitrol. But this was driven largely by patient preferences and informed consent. It's not about the clinician, whether prescribing or non-prescribing clinician. It's not about our goals. It's about informing the patient of their options and helping them make an informed choice based on their values and preferences. And so this is the medication pathways as they came to be. And so the way that they do it at Hazelden is they do a pre-admission, and it's different. They have a different pre-admissions program for opioids than they do for the other substance use programs. And there's a big emphasis on the family there because of the ongoing long-term support and potential treatment. They choose a pathway. There's 3 choices, but you could switch. You know, you may try to taper off and be miserable, and you can go back. Ultimately, they were doing detoxification with mild versus severe withdrawal. It depends on whether you're going to do that. Transitioning into treatment, ongoing assessments and follow-up, aftercare groups, and following up with folks later on. Opioid-specific recovery groups, and then a focus really on lifelong recovery, whether they're on a medication or not. And so many people may end the Hazelden program and then transition to an office-based prescriber in their community. It doesn't mean that the Suboxone, as they use, or the buprenorphine necessarily has to end. So this is the manual. You can contact Hazelden if you want to learn more. They do trainings on it. You can buy the manual. But the purpose of this is now to help treatment providers implement a program like their Core 12 program, and it's got some good bones in it, but you've got to also, you know, consider what they've realized. Not everybody may be able to come in and taper off, right? In fact, we know the evidence shows that most folks won't be able to do that and succeed. But it's got some great bones, and so this is one example that I would commend to you that you can look at, and there's reproducible forms, document templates that can help you standardize workflows in residential settings here. And to shift that agency culture that we talked about earlier, you know, the shift aligns with the appreciation of substance use disorder. In this particular case, opioid use disorder is a chronic disorder, and it requires movement from an acute care model to a chronic disease model of care. We like to talk a lot about substance use disorders. You hear it in the rooms a lot if you're in recovery. These are chronic diseases, chronic disorders. But we can't say that out of one side of our mouth and then out of the other side of our mouth reject its proven evidence-based medical treatment, or else we don't really believe that it's a chronic disease. And so if you think of, you know, like another chronic disease, say cancer, that goes into remission, can you imagine if, you know, oh, you're in remission, good, have a good life, and then they never followed up with an oncologist ever again? There was no support. There was no ongoing checkups. We wouldn't do that with any other chronic disease. So part of what we're doing in that traditional model that we're moving away from, MAT or no MAT, is the importance of aftercare and ongoing follow-up, and that we're not treating an acute disorder. This is not an ear infection or strep throat. We're talking about a chronic disease. And it requires programmatic, organizational, and systemic change due to a greater understanding of the unique and varied requirements to support longitudinal processes of recovery with OUD that can include a medication. And this is a move where we empower the individual to and apply a truly patient-centered approach. That's what we keep talking about, informed consent. What does that truly mean? The patient is fully informed of their choices and the evidence around them, and not pushed based on our preferences or our preconception. They're delivered the evidence, and then we develop an individualized plan around their goals. And it fits the individual with the skills needed to move from clinical management to self-management. And so over time, how can the patients take better care of themselves? And so now back to the barrier about the outpatient integration someone asked about earlier in the call. They have a traditional outpatient program. Let me take a drink, sorry. A traditional outpatient or an outpatient model, and they want to incorporate MAT. You know, if you have prescribing clinicians that get X-waivered, you can utilize buprenorphine products easily. If you already do psych meds, for example, really what a lot of office-based, if you, ReVIDA, what we're kind of developing there, we sort of look like community service boards or community mental health clinics. We just do addiction meds and addiction treatment instead of psych meds and mental health treatment. And eventually we may do both as care continues to integrate for the good of the patient. But, you know, the challenge becomes sometimes in the outpatient programs, if you don't want to do a standalone clinic, you don't have to, right? There's a lot of folks that have you can become certified to do an OTP, which doesn't mean that necessarily you're a, quote, methadone clinic, whether in a residential or an outpatient program. Doesn't mean you have to open a separate outpatient clinic. You can incorporate it into the treatment continuum where you currently are. And so that's what this says. What about methadone? We talked about Hazelden and kind of an overview of their model, but what about methadone? Or even there, Hazelden's is prescription-based, right? What about on-site buprenorphine and naltrexone dispensing? What about not having to fool with community pharmacies? What would that look like? And this would be true inpatient or outpatient. So a lot of folks don't really consider or don't know that residential programs can become certified as an opioid treatment program or an OTP under 42 CFR Part 8, 8.11. So if you go to 42 CFR Part 8, which is the Code of Federal Regulations, it's what oversees an OTP. Historically, when people hear OTP now, historically what those referred to were what we thought of as, quote, methadone clinics. But the reality is OTP is a specific licensure type, not necessarily a specific facility type. And someone can have a federal OTP certification and state licensure and DEA registration, whether they're residential or outpatient, whether they want to do a standalone OTP or incorporate it into their continuum. Historically, they kind of were silos out there by themselves, and that's why that kind of image has emerged. But why? Some of it was stigma. Some of it was for confidentiality of the patient. There was a lot of reasons that it also kind of became a specialty. Some of the stigma, historically, those of us that worked in MAT, we kind of kept to ourselves. You know, we had our own conferences. We had our own professional associations. We did enough CEUs to keep up our licenses, but otherwise we kept to ourselves. And what that did is, because of stigma that happened, that allowed stigma to fester because it looked like we had something to hide, right? But anyway, residential programs, and this is true also for the questioner earlier about an outpatient program that doesn't want a standalone clinic. Your current outpatient program can keep doing everything you're doing and add in OTP services under 42 CFR Part 8. And the federal application is not complex at all. Now, what could throw a monkey wrench, depending on your state, or the state rules and requirements, but even there, it's not a huge bar. I was actually talking to our, one of the, I won't call anyone out, one of the state opioid treatment authorities in the 4 states in which I currently am involved this morning about this webinar, actually, and the use of how we have there's 2 residential programs in that particular state that have OTP certification. And it's not complex. And so you have to, here's some things you've got to submit just to show you how easy it is. A description of the current accreditation status or that you've applied for accreditation. The vast majority, because of third-party payers, residential programs now are largely already accredited by CARF or the Joint Commission. The Council on Accreditation, or COA, is a third of SAMHSA-approved accrediting body. A couple of states, state of Washington and Missouri, have their own accrediting bodies. But otherwise, you know, a lot of the outpatient programs are already CARF or Joint Commission or COA accredited. And so you would simply add on a new service type to that. If you're not accredited, you can apply for accreditation and still get certified and have a year to get accredited. So if you're already accredited, it makes it really easy. You just want to show that you're adding on the OTP standards. What's your organizational structure? The names of the, I mean, this is like, it's a 2-page application with a couple of attachments. What are your funding sources? And this is the part where someone was talking about earlier as a dispensary. I think we overthink that and think that we're going to be kind of setting up a pharmacy. There's a couple states out of the 50 that have pharmacy board involvement in OTPs, but most don't. And so, you know, once you have your state licensure, you can, for this, you apply with the DEA, again, a very simple application to be registered as a narcotic treatment program. So you would have to add a safe if you don't have a safe, a DEA compliant safe. And again, that's not hard. These are very easy things. And you could dispense all 3 currently approved FDA meds on site. The good thing about the OTP certification is you're pretty much set up to dispense any new FDA-approved meds on site regardless of their schedule. So OTPs are the only facility type, licensure type or certification type, I should say, that can utilize all 3 FDA-approved meds. And so you can actually dispense the buprenorphine on site. You can dispense naltrexone on site. So if you're in a residential program, we talk about doing that oral naltrexone first. The reason oral naltrexone never took off, even though we've used it from the 80s, since the 80s, as we talked about, is the low adherence. Well, if you have an OTP certification in your residential program, you have a controlled environment, you have a captive audience, right? You can give them the oral naltrexone every day, and it's significantly less expensive. We're talking cents, dollars to have the oral naltrexone, and then transition them perhaps to the extended release injectable naltrexone when they transition out of care. Obviously, if you're a hospital, your program has hospitalization, you already probably have a pharmacy and stuff, so we're talking more about the residential programs or outpatients that are non-hospital. Also, if you're outpatient, because you want to try the oral before you commit to the extended release, you will be able to dispense oral naltrexone. You'll be able to dispense buprenorphine products, or regardless of name brand. And you'd also be able to dispense methadone. And so you can do this residentially, and you can do this outpatient, and you don't have to change anything you're currently doing. You add in another service type. Now, would you have to have a room for your safe and a dispensary? Yes, you would have to, those specifications. And so I'm not saying it's just pieces of paper, but it's not hard work, you all, I promise. And there's consultants out there that will help you figure this out as well. If you're already accredited by CAR for Joint Commission, call them up. I bet you they'll know of consultants that can help you if you want a consultant. Again, there's that technical assistance I was telling you about, your tax dollars at work. SAMHSA has TA that will help folks become accredited as OTPs. And so it doesn't mean to have an OTP certification, you have to open something that's just an OTP. In fact, the hope is, as we move forward, that care continues to integrate in a way that patients have a variety of levels of service in each continuum, be that residential, especially in outpatient programs where eventually we could do all 3 meds. We could do dispensing and prescribing. Perhaps we could do primary care and treat mental health there, integrated care, because we know patients are more likely to get the services they need if we offer them all in one place. And so again, that OTP certification with SAMHSA and the NTP registration with the DEA, along with whatever your state requires, allows dispensing all FDA-approved meds on site. You've got some nurses in your residential program. You've already got CAR for Joint Commission or co-accreditation. You add on OTP. You do some paperwork. You buy a safe. I mean, I'm simplifying it, but it really is not much more difficult than that. Obviously, you need policies and procedures in place, but again, there's TA out there for it, y'all. This is not, it's not hard, okay? All right, and OTPs also, here's the other thing, that nurse practitioner earlier, our colleague that brought up her slots and how that's limiting her. If you have an OTP certification, you're not subject to patient slots, y'all. A lot of people don't realize that. That's only for X-waivered prescribing. When you're dispensing, you're ordering and dispensing, like in a hospital, right? It's an order and it's dispensed through a dispensary on site. There's no patient slots, none. X-waiver is irrelevant. In fact, your doctor or nurse practitioner don't even have to have an X-waiver to order through an OTP. That's only to prescribe buprenorphine. That's all that's for. And so that's something a lot of folks don't realize. So if you're in an area where the slots are a real concern, or there's not an X-waivered physician, or you've got one provider but can't recruit another one and they're doing good, and you have a multidisciplinary team of nurses and therapists, social workers, peer support, peer recovery specialists that can really help support that doctor, you can treat as many patients as you can stand and meet the, do good care for with an OTP certification. So to think of these as standalone entities or methadone clinics is just not what they have to be. And so you can add this certification and this service to existing outpatient without changing anything you're doing in the same location, as long as you can, have a place you could build out your dispensary and your stuff A residential, even easier. And if you're not accredited, again, doesn't mean you can't do it. It just means you need to apply for it. You don't have to be fully accredited to apply. SAMHSA will give you what's called a provisional certification for a year to give you time to get accredited. And so, again, OTP certification is not just about methadone. It's about all three meds and any other FDA-approved meds in the future. It's not about standalone siloed programs. It can be integrated and should be integrated into the continuum of care.
Would you like to hear some questions and feedback?
Yes, let me do this one more point and then we'll stop. So the last bullet point here, I just want to, so if you don't want to go OTP certification, is there an OTP in your community? Is there an office-based opioid provider in your community where you could develop a memorandum of understanding? You also have to have certain chain of custody in place to satisfy DEA to facilitate that, because in our office-based program, sometimes we'll have patients that are also struggling with other substances, or maybe they need residential, but their OUD is stable, but maybe they need some residential or a higher level of care for a stimulant use disorder. Why would we destabilize their opiate use disorder to treat another one? It's like having to treat, choose between your blood pressure or your diabetes. We don't do that with any other disease. And so, would you partner with OTPs or OBOTs, even if you're not ready to do OTP certification or really incorporate MAT into your milieu? How would you partner with others to potentially provide these services to folks that are in your residential care? And so there's a whole nother area you can go in that way as well. All right, so we'll take some more questions now.
So the first is just a comment that says the information about residential programs becoming certified as OTPs is fantastic. Thank you, with a bunch of exclamation points.
You're welcome.
And then we've got some other questions here. This is another question from the same person that was interested in MAT in their outpatient program. They asked if there's any specific manuals or guidelines that you know of for that.
So that's what for incorporating it into the existing outpatient, I assume is what they're asking.
That's my assumption.
There's really not. Here's what I would recommend. If I were talking to somebody, I'm a sucker and would probably just help them. But here's what I would recommend. Every state has what's called a state opioid treatment authority, or a SOTA, SOTA. There is actually I'm looking at my slides right now. I was about to say I could put it in the chat box, but I can't right now. There's a SAMHSA directory. I believe if you just Google SOTA, S-O-T-A directory, SAMHSA, it'll come up. And you can pull down, it's a list of all the 50 state opioid treatment authorities. I would email them and explain what you would like to explore, because they're going to be the bridge between the feds and your state rules that really kind of understand both. They're the ones that have to give the final sign-off to the SAMHSA certification. And they would also know if there were what state requirements were there. So I would reach out to them. If you are already accredited, I would reach out to my accreditor, CARP or Joint Commission. If you're not, I would reach out to one of those, because they will guide you. I mean, the accrediting bodies are really great about walking you through a lot of the process. And beyond that, reach out to SAMHSA for TA, technical assistance. I mean, someone will literally, the federal government, your tax dollars, someone will come out and help you develop your policy, help you walk through the application. And so that's kind of the trifold approach I would take, or I would recommend to someone.
All right. Another question is, this is a person from the Maldives. I believe that's the right pronunciation. I've never actually known. But they said that they are going to open their second MAT program, but they're finding that the heroin being used there is cut with benzodiazepines, and they're concerned about the implications of that.
So that's a good question because I've mentioned benzos before. We need to be cautious about benzos, but we don't need to become hysterical. There are some patients, again, it's like choosing between blood pressure or diabetes. There are some patients for which there will be a legitimate medical need for benzos. I'm not talking about cutting heroin, but I'm just saying as a whole. And that's where coordination of care and a skilled physician comes in. My doctor, we don't not admit if they're benzo positive. We're aware of that. The doctor may further individualize their dosing titration and things. And if it's prescribed, we need to talk to that prescriber and see if there's a legitimate medical need. Because you also don't want them to abruptly stop taking benzos, as I'm sure most folks know, because it can cause a lot of negative impacts, seizures, and it can be very dangerous. So you need to be aware if they test positive for benzos at admission. The first dose is usually somewhere between 20 and 30 milligrams if they test positive for benzos. Also, are they in withdrawals at admission? If they're in severe withdrawals and not sedated, even if there's benzo metabolites in their urine, again, that's a medical decision, but it's highly unlikely if there's anything that's going to contraindicate induction with methadone or buprenorphine. So again, it goes back to individualized care and having physicians that are really understand what they're doing. There was some guidance from the accreditors on this. Was it ReVIDA? It might have been the ATTC that actually put out with Philadelphia the benzo kind of guideline in MAT that's really good. So we need to be careful not to force all patients, again, any blanket policy, like no benzos ever, no matter what, with MAT. Any policy like that that's blanket is really the opposite of individualized care. Now, the vast majority shouldn't be on it, but, blanket policies on individualized care. And so we don't need to become hysterical, but we need to be aware of it. And so, my doctor, again, she would have to evaluate the patient. And were they actually in objective symptoms of withdrawal at admission? Were they sedated? If not, she may give them less of a starting dose, may take them up a little slower and continue to monitor that. But you also run the risk of not stabilizing the dose. They're going to continue to use illicit things. And so there's a fine line there, and that's why care has to be individualized by a skilled clinician.
ReVIDA that worked on that guideline, and we can send that out to participants as well.
There's a plug. See, so ReVIDA has a really good guideline that they have offered to send out to you, and it's and it really addresses that and kind of goes into that individualized approach.
The last collection of questions are a little bit all over the map.
That's fine.
Are there any psychotropic medications that may have an adverse effect on the effectiveness of MAT? And are there any longitudinal studies that support the strength of MAT alongside psychotropic medications?
So those are really great questions. To the first question, I would say, yes, of course there is. I can't rattle off a list to you. Like any other prescription medication, when someone is going to order or prescribe it, they are behooved to check for drug-drug interactions. That's really the responsibility of the prescriber. There are a lot of really good drug-drug interaction checkers now. We used to have like PDFs that we would look through, but these days, you can run the interactions fairly easily. Make sure it's a credible one, but most of them, there's not really contraindications, but there are a few, and so you need to be aware of that. Certainly, we do have some studies that show, the most recent one that shows, when you're treating the co-occurring mental disorder alongside the substance use disorder, that you end up having improved outcomes with both disorders. And so we kind of went away with the DSM-5 from this notion of primary versus secondary diagnoses, right? They're all just co-occurring now. We still list them in a certain order, and the one listed on top is the one that we think should be addressed first, but the reality is they all have to be addressed. And so we do have some data, some objective evidence that shows we have better outcomes when we treat both, including both with and without other mental health meds. But off the top of my head, I don't have, that I can pull up right here, right now. But the answer, very generally speaking, is yes. We have evidence that it's safe and effective and that actually it improves outcomes on both sides.
Okay, and this person used a term I'm not familiar with, but he explained it pretty well, I think. So they say, can we talk a little about some of the incidental medical services that need to be addressed and offered for our patients within our residential sites? In California, we have licensure for incidental medical services. These are medical services related to the treatment of SUD, but not physical health. And it says this is where we're running into the question, which is drawing a line between detox and WM, which I think is withdrawal management.
So California, let me start by saying this, is unique when it comes to maintenance and OTP state certification. So California still has this archaic state rule that one has to first go into detox and essentially fail before they can go into maintenance. And by detox, the definition is there's short-term and long-term detox, but essentially it's 180 days or less of decreasing doses. And so that's likely where you're having these classifications. So what a lot of OTP providers in California do is they bring them in on detox, start them on 30, take them up to 40, hold them, take them down 10, document, they still have withdrawals, and then they can put them in maintenance. So some of that is, believe it or not, as progressive as California is in many ways, has some really archaic OTP state rules, and so that's likely what's at play there. But the reality is we've got to move towards integrated care. Michael Freeman, the California SOTA, is very progressive thinking. A lot of this is up to state legislatures. So do you have a providers association there, and are you trying to change some of these rules? But as to the specifics around those nuances with California, I'm not able to speak to that. It's beyond my expertise.
Okay. Let's see. There's a question about training for medical students. Do you have any recommendations, like the SCAPE Fellowship here at ReVIDA or the Betty Ford Fellowship, for externships that you can recommend for medical students to get clinical experience in this area?
So depending on where you are, if you're involved with a medical school or you're a medical student, we've got to see more of that. I mentioned earlier on that Brown University is doing a cool thing that was just announced. We're seeing more students do that. I was just talking to actually, this is not medical, but pharmacy students from the University of Tennessee about doing some rotations with them, even though we don't have to use pharmacists, just so when they get out into the community pharmacies, they don't freak out if somebody comes in with a Suboxone prescription. And so that really is a case-by-case sort of MOU. Are there OTP or OBOT providers in the area that are willing to engage in that sort of an agreement? But off the top of my head, I mean, I don't have a directory of such, but I would look to, the aforementioned ones in Brown and see what they're doing. But if you're in an area and there's not really anything going on and you're involved with a medical school, I think the time is right that a lot of providers would welcome not only help educating folks to get them the experience, but, we all like free labor too. And so that's really the best I can go address that.
Okay, great. So this person kind of goes all the way back to the issue of impairment and opioid agonists. Sure. They say, if there's no impairment, why are commercial drivers prohibited from driving while using methadone?
Because of stigma.
Period. And
that's, I don't know what else to, because in fact, I was just talking to a medical review officer at that Tennessee Chamber event I was referencing earlier. And again, if you go to the Legal Action Center, which is LAC for legalactioncenter.org, and you go to their MAT resources, they've got a compilation of all the psychomotor studies on methadone-maintained patients, and there's no evidence that they're impaired. And so that one remaining reg for CDLs that no patient that's been denied that's on methadone has yet sued for to have it thrown out, or we've just not focused on the legislation there. That's a big gap in our public policy, but there's no evidence that supports that. And so my answer, yeah, it would be stigma, period.
Okay. This says, our outpatient facility has successfully integrated extended release naltrexone and buprenorphine and are currently in the process of DEA licensing for injectable buprenorphine. Do you have any experience with Sublocade, and are there any resources you can provide?
Love the idea of Sublocade.
Yeah.
I love it. There's another new one that's very similar to Sublocade that was just approved, and I can't think of the name, but it's going to be weekly versus where Sublocade is a monthly. The problem there is, well, I don't think it has to be a problem. I think it's something we just need to recognize. Much like starting someone on a monthly injection of Vivitrol, especially outpatient, if you bring them in, stabilize them, and quickly move to a monthly injection, and if they need access to the other ancillary services or comprehensive services, the way in a lot of our OBOTs, just to be quite frank, if they didn't have to come back to pick up that prescription, they might not come back in. And so I think we need to be aware of that. For our more stable patients, I think it's great. For residential, like if we have a patient, like I talked about earlier, that's a great way when we're talking about MOUs to partner with residential or residentials to use something like that. We're talking about an injectable. I don't think diversion is something that our inpatients need to freak out about because it's more controlled than anywhere else. There's a lot of policies and procedures you can put in place but it really takes that away completely in an inpatient or a controlled environment. I see Sublocade being used, a real solution in the criminal justice system as well for the jails and prisons that don't want to develop their own OTPs. And that's another thing we're not even going really into today. Sarah Waitman and colleagues out of Boston just published a paper. I was just reading, it just came out, that really deals with jails and so on. And in Boston, they've got it now in the jail. And so we've got it in the county jails in D.C. Of course, Rikers Island has had it for years. And so I think that Sublocade and some of these injectables have a real chance to help us either with stable patients, because, I mean, who wants, people, stable patients have to, Americans forget to take their medication, and so whether that's your blood pressure pills or your Lipitor or whatever. And so anytime we can eliminate that with any medicine, it's a good thing. And so, I think Sublocade has a big opening. I would just say we need to be aware of how soon we start people on something that lasts a month and are they at a good place before we do that. But I think that the more options we have, the more tools we have in the toolbox can only be a good thing.
I guess I just want to point out that we probably only have about 5 minutes left, so I'm not sure. Is there anything you want to make sure you get to, or do you want people to...
I want to share a couple quotes to that stigma and the CDL thing, for example. The World Health Organization said this, that the stigma associated with substance use can prevent individuals from seeking treatment and can prevent adequate policies regarding prevention and treatment from being implemented. And whether that's true on the Department of Transportation or whether that's true in our traditional residential programs that have looked over the evidence because of stigma, I think that's some wisdom we need to take in there. This is Herman Joseph, who I mentioned earlier, and he was talking specifically about methadone when he said, no other medication in the history of modern medicine has been so unjustly maligned. The stigma that methadone patients feel is a real phenomenon, and in comparison with other social stigmas, appears to be entrenched in the collective social consciousness of the country at every level of society. And that really leaves us something to think about. And lastly, getting here, Dr. Dole, who I mentioned earlier, is really the godfather of MAT. I've mentioned him a couple of times. This notion that MAT is nothing but a substitute and a crutch, right? If you trade one drug for it, it's just a crutch. You're not in recovery. He addressed this notion in '96 when he said this, and I think this is just really great. That seems like a vague charge that has no answer. A crutch is not a bad thing if you have only one leg. Yet it's not nearly as good a solution as it would be if you could regrow your missing leg. But since we can't regenerate a leg, why not use the crutch to get about and lead more normal lives? And I think that's what I want to leave y'all with today. And if we have time for another question or two, we can do that. But I'd like to leave us with that. Why? It's about quality of life, keeping people alive first and foremost. But people have a right to have a quality life and to have informed consent driven by the evidence. And so if we can't regenerate a leg, why not use the crutch?
Well, thank you so much, Zac. We do have a question here about someone that I think probably would be interested in some TA and guidance around stigma reduction and utilization of MAT. And I wonder if we are able to hand out your email address so that people could contact you directly if they have questions about implementation in their area.
Sure, that's fine. And if I'm not the right person, I can certainly kick them in the right direction. That would be fine.
Okay, fantastic. And we have a comment here about the dental. They say, thank you so much for the answer about dental health. That's a great response. And I thought the same.
You're welcome.
And one last question. So this goes very, very, very far back to the beginning of the presentation, looking at the MRI, the brain images. It says, how long would it take for the brain of someone who stops using opioids but has not been treated with MAT to normalize so that it looks like the point of someone who is undergoing MAT?
The answer to that is like any other medical condition. We're talking biopsychosocial, so it depends on their biology, their genetics. It depends on the length of time they used, how they used, what they used, how much they used, and all of those things. We also know that trauma greatly impacts the brain, even structurally. Were they exposed to trauma? Has that been treated? And so there's not. We can't, just like we can't have blanket answers when it comes to the treatment of chronic disease. We have general evidence we work within, but everything has to be individualized. So too, that answer would be, depending on all of those factors. It could be a couple of years. It could be a lifetime. Others may never fully normalize. And so, that's why we have to have skilled clinicians addressing this issue, and we have to take it case by case and look at what are the objective signs and symptoms, what are the subjective symptoms and self-report, what does the evidence show, are we making progress or are we not? And that's really the only way we can measure it, because the PET scans are great and they tell us a lot, but we can't do PET scans on all the patients we see, right? Mm-hmm. And so there's really, the answer is it varies.
Well, fantastic. I want to thank everyone for attending, participating, asking questions, and especially I want to thank Zac. Thank you all for such a great webinar, and 2 hours was sort of a marathon for everyone, so thank you for sticking around. And now, Zac, if you don't mind, can I take the presenter mode back so I can give people some kind of boring instructions about CEUs?
Absolutely.
All right. So here I'm going to pull up a quick image of how to access your CEUs. Let's see. So as I said before, let's see from the current slide. As I said before, this webinar is approved for 2 NADAC and PCB CEUs, which are free. It's also approved for 2 social work continuing education credits, and that's just going to be a $10 fee, and you'll need to request those by the 10th of March. We would really like it if you would fill out our evaluation form or fill out our evaluation survey. It's very short. It only takes 2 minutes of your time, and it really helps us understand what works and what doesn't work for you about our training so we can make them better. So basically, when you, in order to get your CEUs, you're going to want to log into your MyReVIDA account, click on the title of this webinar. This is not the title of the webinar on your screen. It's just an example of what it will look like. And then in order to get your CEUs, you'll want to scroll to the bottom of the page, and you can select whichever one you're interested in, including a certificate of attendance. It generally takes us about 48 hours to cross-check your attendance, so the certificates and CEUs will not be available immediately, so please be patient. And I wanted to let you all know that we've got another webinar coming up next week. I think it will be also excellent. It's called Motivating Change Talk, May the Force Be With You, and it's presented by Dr. Robert Chapman. So please register for that. It is, of course, free. And overall, we'd love for you to connect with us in all sorts of ways. Social media and via our newsletters would be terrific. And finally, I know everybody's going to be interested in a copy of the PowerPoint and the recorded webinar. We'll send those to you directly, probably in the next couple of days after they're posted. And you can feel free to share it with people who you thought might be interested in the topic but weren't able to attend live. Again, I want to thank you so much for attending, and Zac, thank you so much for presenting. And if you have any questions, send us an email. The email address is info@ireda.org. And with that, I'm going to conclude the webinar. Thank you, and have a great afternoon.